Hello, everyone. I'm Whitney Espick, CEO of the MIT Alumni Association, coming to you from just off the Infinite Corridor, and welcome to the April MIT Alumni Forum. Last month, the world watched with excitement as NASA's SpaceX Crew 9 returned to Earth from the International Space Station after nearly a 6-month sojourn. Of course, we in the MIT community also watched with pride, knowing that the spacecraft's commander was U.S. Space Force Colonel Nick Hague, whom we are proud to call a Course 16 alumnus. He follows a decades-long tradition of MIT graduates who have ventured to the stars to help us gain more understanding about our planet and its place in the universe around us. Have you wondered, though, what are the impacts on the very human bodies of these intrepid travelers as they traverse through the celestial ones? To help understand these unique circumstances a bit more, we are delighted to have with us on today's forum Lonnie Petersen, the Samuel A. Goldblith Career Development Professor of Applied Biology at MIT, and also the Charles Stark Draper Career Development Professor of Aeronautics and Astronautics. As a medical doctor and engineer, Lonnie is a leading expert in developing devices and strategies to support human health during long-term spaceflight. Joining her in conversation is our moderator, Thomas Help, PhD, HST 2004. Thomas is an Associate Director of IMES, Associate Professor of Electrical and Biomedical Engineering, and Principal Investigator for the Research Laboratory of Electronics. He also directs the Integrative Neuromonitoring and Critical Care Informatics Group in IMES and RLE. If you already have questions on our topic, feel free to start adding them to the chat box below and upvote the ones you find most interesting too. Please also note that closed captioning is available, which you can access by selecting the CC icon in the lower right corner of the video player. And now, with all of that in place, I'm going to pass it over to our stellar speaker, Lonnie Petersen. Lonnie.
Thank you very much, Whitney. Thank you, Whitney, and to the associate or the Alumni Association. It's a great honor to be invited here. So it's a great honor to be able to share a little bit of my work, introduce my lab. It's the Aerospace Physiology Lab. My home departments are Aeroastro and IMES. I have a footprint in HST, and this is my lab. And this is my myself and my titles. I brought this snapshot of the bio primarily to set the scene for the work that I do. So my clinical background is from anesthesiology, primarily from the intensive care unit, and I've specialized in critical care. My real passion is actually the pre-hospital care, the remote area care, and as such, I've served in very remote areas. For example, being regional physician in Greenland, and that allows me to bring this beautiful screenshot of my second home here on the screen. My PhD is in gravitational physiology and space medicine. And if you think about it, space medicine is just really, really, really remote area medicine. So it does actually all tie together and fit under one umbrella. I've been a faculty or a professor of aerospace engineering for many years now. And you'll see all the work and the projects that I present, they do sit in that cross field between medicine and engineering. I'll try to highlight a lot of the spin-up application and the spin-down applications between Earth and space as we go through this. So when I received the invitation for this, just as you guys, I saw the title, so thank you for that. And this is actually a great place to start. What happens to the human body? What does it take to ensure that our crew will thrive during space missions and be most productive? And it begs the question, what even happens to the human body during spaceflight? And lots happen. In fact, almost all parts of the human body and our function are affected during a stay in weightlessness and partial gravity. And you see this by all the little lines going into our little astronaut here. The weightlessness will cause our muscles to atrophy, our bones will decalcify, something that almost is akin to osteoporosis as we know it here from Earth. Gastrointestinal tract is impacted, our immune system is impacted. heart and arteries, the cardiovascular system is impacted. Sensory motor, performance, our exercise capacity, many things are impacted, even the brain and the eye, which is what I'll talk primarily about today. And so we develop countermeasures to prevent some of these changes, the ones that are negatively impacting the human. We develop countermeasures to keep our crew alive, healthy, happy, and thus productive doing space missions. When that fails, or when disease or trauma occurs in space during space flights, we develop a system for medical capability so we can intervene and again ensure human health even in this very remote area. And so all of that and more is encompassed in this field of research that we call bioastronautics. And it is really a broad field. It includes biology, physiology, behavioral, and medical aspects of human space exploration. And this is indeed, as mentioned, a very exciting time. It is perhaps arguably the most exciting time to date that we've ever been in for human space exploration. It's almost a new era. And a lot of that is actually driven by the strategic commercialization of low Earth orbit. What that drives, or the consequence of that is that we're now flying crew that is way more diverse than previously than our professional crew. Larger age range, some have comorbidities. We can no longer simply just select our way out of the risks associated with spaceflight. We're flying people that are way more similar, physiologically speaking at least, to you and me in space. So that increases the diversity of our crew. The commercialization of low Earth orbit has also enabled many of the agencies to really turn their focus to exploration class missions. That gives us longer missions and further away missions, so increases the autonomy dramatically of these missions as we go to Moon or Mars. And in combination, this means that the challenges and the requirements for how we keep our crew safe and in high performance really has changed. And that's why it's so exciting to be specifically in this area of research right now. And so that's what my lab is interested in, understanding the effects of spaceflight and developing countermeasures to keep our crew healthy. It includes a lot of technology development and obviously a lot of human research. One specific area of that, and I'll dive into all the nitty-gritties of this now, is those changes in the brain and the eye, as I alluded to. We know that when astronauts spend weeks or months in space, their vision changes. It becomes more blurry. When you investigate the eye, look at the eyes, there are structural changes and swelling at the back of the eye, the posterior sections of the eye. That is sort of the underlying structural changes leading to this functional reduction in visual acuity. If you look even further back into the central nervous system, into the brain, you also see structural changes and remodeling of the brain tissue itself. We see this as enlargement of the fluid spaces, so there's fluid accumulation inside the brain. NASA has classified this as a major risk of spaceflight. It is important to develop countermeasures for this, even though we don't actually fully understand why this is happening. We don't fully understand the pathology leading to this. It's a focus of my area and my group to understand the regulation of the pressure and the flow through the brain. And so even though we don't fully know why this is happening, we do have hypothesis, and this is the leading hypothesis as to what is driving these changes. So when we're standing here on the surface of Earth, or you guys are sitting in front of your screens, the stress of gravity will pull blood and fluid into the legs, into the lower abdomen, and so away from the heart, away from the brain, and that actually keeps the pressures quite low in these headwards vascular beds. And actually finding out that normal ICP pressures are negative, even in healthy people, was a big component of my graduate work back in the day. This does not happen in space. As soon as you enter the microgravity or the weightless environment, blood is more evenly distributed, and it leads to a relative increase in the filling of the heart, and likely also above the heart, so in the brain. And that is likely one of the driving factors as to why we see this overload, this fluid accumulation inside the brain. It's a great hypothesis. Of course, you have to test these. And so some of the early work that we did to understand the impact of the brain and the pressures and the flow doing weightlessness was to measure the brain pressure and weightlessness. And so we got the weightlessness using parabolic flights, and I'm sure you're all familiar with them. You allow a plane to perform a free fall following the parabolic trajectory, and it gives you some 20, 30 seconds of weightlessness. This here is the hero of the day. This is our test subject. She's a cancer survivor. Because of her earlier diseases and treatments, she has a port embedded in her skull, and through that, the end of that actually sits inside of her brain, and through that, we can then measure the pressure inside her brain. So even though she's perfectly safe and healthy, we can measure the pressure inside her brain through this port. We did that. We also put a catheter in close to her heart in the central vasculature, and we measured many, as much as we could think of, parameters from the eyes. Many publications later, I'll just skip to the conclusion of this, but what we found, or we were able to conclude based on all this work, is that it does in fact seem that weightlessness will cause a low and slow, but chronic sort of overload pressure and volume-wise of the cerebral structures, which could be the driving factors of this seance, of these changes in the brain and the eye. So that's good. Next step would then be to find a way to counteract that. And so towards the countermeasure development, we've now semi-understood this part of the process. We would like to then get back to these nice low and unloading those cerebral structures. One way of doing that, and one way that my lab has focused on for many years, is to use something called lower body negative pressure. At the heart of it, this is a very simple method. It is an airtight chamber. It can look in many different ways, but an airtight chamber that covers the legs and the pelvic area of the person. You can then decrease the pressure inside of this box, and then sort of displace or suck blood and fluid back where it belongs, down in the legs. And in theory, that would then unload these structures towards the brain. This is what that could look like. This is one of the ways it looks like in real life. This is one of the chambers that I built, and this is one of my patients. And you will see that she actually has a little catheter protruding up here. This sits in the brain parenchyma, in the tissue of her brain, and so we can directly measure the pressure inside her brain. I've tilted her slightly head down. This is actually a common simulation of weightlessness. It sort of mimics that fluid shift towards the head. And then she has her lower part of the body inside this chamber. And when I drop the pressure in here, I can pull blood and fluid back in this area. And so this experimental setup allows me some control of the fluid shifts inside the human. This is data showing the effect of the intracranial pressure, so the brain pressure, as a function of this LBNP, lower body negative pressure treatment. What you see here is the brain pressure increasing as we're tilting her down, letting blood flow towards the head. And then it comes back down to normal safe values as we increase the negative pressure inside the box. And so this allowed us to understand the dose-response relationship of the LBNP and the direct effect of the intracranial pressure. This bottom panel here is just to show you the effect of the cerebral perfusion pressure. That's the feeding pressure to the brain. And it's mainly, I include it mainly to show that we're not taking anything away from the arterial side of the physiology. There's still just as much blood, arterial blood running through the brain, feeding the brain. And in fact, we can restore it if this has been compromised. And so this seems to work, but it's not super feasible to fly these big chunky boxes in space and have our crew spend the whole mission inside of a box. So one of the technology development push that we have tried to further in my lab is to translate this technology into a wearable and mobile and flexible device. And so if these work, you'll just see some rendering of how these devices, how we model this. These are actually undergraduate projects, and so I'm quite proud of the amount of work produced by the undergrads. The last one here is one of our early prototypes, and this is actually while undergoing that pressure treatment. So there's negative pressure inside these pants. And as you can see from the slightly goofy smile, it's quite comfortable to wear these. So we think this could be a feasible way to reduce those changes or counteract those changes in the brain. Current work or current efforts in the lab are now geared towards maturing this technology and this methodology for flight for implementation in space. To do that, we need to increase the technology readiness level and the countermeasure readiness level of a hardware. And so we have put this on more parabolic flights. The very first one was actually last year using the MIT parabolic flight platform. And that went well, so good that we were able to now implement our experimental setup on the European spaceflight parabolic flight platform, and we'll be flying this again in May, September, and November this year. And the updates now include added safety features, a control feedback loop to really allow us to adjust the dosage of the LBNP and really titrate that based on the physiological response of the patients to allow for sort of a personalized countermeasure approach to this. But astronauts are not the only patient category that may struggle with either too much pressure or too much fluid in the brain. This is also a clinical challenge in a normal clinical everyday. And so I show this as one of those examples of technology developed for astronauts, but that have clinical applications, spin-down applications for our patients here on Earth. So many instances like trauma or blast injuries or even just spontaneous can lead to elevated intracranial pressure, so too high pressure in the brain. And bringing that pressure down can be life-saving. So one of our pushes has been to further develop the hardware and turn it into a medical device. And what you see here is just an example of one of our very first clinical trials, trying to maintain or control the pressure in the brain for this traumatic brain injury patient as a form of bridging treatment until either the swelling subsides or we can perform life-saving surgery. So there are many examples of spin down where research or technology created for space benefits our patients here on Earth. And so I'll stay in this realm of medical capabilities just for a little while. And this is just to show you a new development, a new leap, if you will, in our medical capabilities in space. This is the FRAM-2 mission that many of you may have heard about. They flew last week. So this is truly data fresh off of the press. The FRAM-2 was a pioneering commercial crew. They are, in fact, the first humans to ever orbit the Earth in a polar orbit. In addition to that, they also performed a lot of science, a lot of research during their mission, including ours, which is the Space X-ray project. And so here it is. What you see on the left here is the first medical X-ray ever taken on Earth. It's taken 130 years ago by Dr. Röntgen. And on the right, you see the first medical X-ray ever taken off of Earth. And this was taken last Wednesday by the Frame 2 mission. And so in trying to get towards what is the challenge of that, why bother with that, what is even the difference? There are many differences between acquiring an X-ray from the radiology department at Mass Gen Hospital and then in a super remote area like space. One of the things that I was particularly interested in seeing was the impact of the increased background radiation, whether that would reduce the quality of the image and take away from the diagnostic capabilities. There's also a lot of procedural challenges in the X-ray department. We have gravity to help us align the patient relative to the radiation. And so in space, everything floats, including our patients. And so the procedural aspects of this were a specific aim that we tested. We also were not able to send any of our radiologists or X-ray technicians. And so translating a lot of these medical procedures to be used by non-specialized crew is always a specific aim of these trials. And if I take off my physician hat for a while and put my engineering hat on, I just want to also underline that we use X-rays for non-destructive testing for material integrity and to investigate devices without taking them apart. We've used that in aviation since forever, and we now have that capability also available in space. And so with that, we've increased the diagnostic capabilities, not just for patients, but also for hardware. All right, and so in the last 5 minutes or so, I will talk a little bit about a different area of research because we are the Aerospace Physiology Lab, but we also have aero in our name, and some of our applications or our work does apply inside the atmosphere. And so I will talk a little bit about some of our aviation projects. This really focuses on aerial medical evacuation, so medevac, or casualty evacuation, CASEVAC. When you fly patients either in a warfighter situation, bringing them out of an active battlefield, or in a congested urban area, picking them up from a site of an accident, or in very remote areas, flying patients really induces an additional environmental impact or additional environmental stress on them. And so this includes acceleration, G-loads, vibration, turbulence, particularly in the warfighter situation or application, evasive maneuvers if you're trying to dodge hostile fire. There are altitude changes and temperature changes. And so any one of us that's ever transported a patient know that patients have reduced tolerance. We have to be careful, particularly if they've lost blood or for other reasons, they're just hemodynamically unstable. We know this, but there's actually surprisingly little data to support that empiricistic knowledge. So it's difficult for us to fully quantify that reduction. How do we fly them? We also are not able to create robust models to understand these patients' physiology. And therefore, it's difficult for us to fully mitigate this risk. And in fact, NATO, the Safe Flight Standards created by NATO has listed the lack of human data as the #1 obstacle for improving aerial evacuation. So that's where we started. We wanted to create some of this human data to push this field forward, to advance this field. The first line of research that I did to meet that aim was to use a human centrifuge, so a long arm centrifuge. What I wanted to do was to quantify the reduction in tolerance to these G applications. So we created a relevant G profile mimicking evasive maneuvers. We then spun a group of patients and measured the physiology response. Then we used the trusted lower body negative pressure device again, the LBNP. We turned the pressure up a little bit more and really sequestered blood in the lower part of the body, and we did that to simulate blood loss. Then we spun them again in the same G profile, and we evaluated the delta values. And so just as a brief snapshot of what we found, if you look at the red squiggly line here, this is the acceleration, the G load. And so this first here is just flying straight and level, no drama, no interesting, just flying straight and level. This illustrates the simulated hemorrhage. So this is taking about 15% of the blood volume away. And so flying straight and level while having not all your blood, or while having undergoing or having blood loss. If you look at the mean arterial pressure, the blood pressure, it's actually fine. We can all survive, or we can all withstand losing about 15% of our blood volume. The blood pressure will be fine. In this middle panel here, we let the patients keep all their blood, so to say, but we flew them in these pretty evasive or aggressive banks, so steep turns, and they pulled upwards of about 4 Gs, really briefly, but about 4 Gs around the corner, so to say. And again, if you look at the blood pressure responses, that's fine. We can all kind of withstand that. There's a little bit maybe, but it's almost inside the noise. So again, the human body can overcome this. If you look at the last panel here, we combined those two interventions. So took away the blood volume, flew them in this aggressive flight trajectory, and now you see that the blood pressure actually significantly dips. It almost crashes. If you look at the values, we managed to reduce the mean arterial pressure to some 40 millimeters of mercury. So this is a significant reduction. This is definitely something that will get the EMT or the flight surgeon's attention. So very interesting data, certainly worthwhile understanding the synergistic effect. And so ongoing work now really is focused on chasing down that. We're doing that in multiple ways. One of them is in collaboration with Boston MedFlight. We transport patients on helicopters and fixed wings many, many times every day. And so on these flights, we are taking the opportunity to record the G vectors, the vibration, temperature, everything that goes on, and then we map that onto the physiology, both from the patients, actually also from the pilots and the colleagues in the back of these planes. And so if this works, I included this. I know that this is the Alumni Association, so everyone has lived at some point, at least if you don't anymore, in beautiful Boston. And so I do love this film clip. This is taking off from the helipad from Boston, from Mass Gen, and just giving you a beautiful day, a panoramic view of the Charles. And this is after dropping off a patient at Mass Gen. All right, the last leg of this data collection or these trials is to collect the same type of human data, but in a more uncontrolled setting, or in the wild. We have the highly controlled centrifugation setting. We have the patients where we don't have a control situation. This collaboration with the US Air Force and the test pilot school allows us to really put our experimental setup into a plane in actual air in mid-flight and perform these evasive flights, these aggressive flight trajectories. And we performed these trials actually last month. You see here this is a flight tracker. So this is real time showing our experiment flying on an available app. It just shows our plane. Again, we had the simulated hemorrhage experimental setup inside the plane. We've collected some quite unique data. We're still analyzing. They look very similar to the data I showed you from the centrifuge. We're using these data as the basis for creating some modeling to understand fully the physiological responses. We can create prediction algorithms. We can use those to optimize the flight algorithms that control these planes. And the ultimate goal really is to fly based on the patient status here. Ultimately, if we can automate this enough, this is the background for creating a drone ambulance. And obviously, this line of research is near and dear to me, both in Greenland, Alaska, other places. We have no roads. We fly all of our patient transports and evacuations. And so it's the driving or the motivation factor for this really is that I would like these data. This would benefit me when I was the physician up there. It also has space applications. In the event that we need to do a rapid deorbit maneuver for sickness in space or acute illness in space or trauma, the space ambulance, these data will be significant to understand how to safely evacuate our crew. And so with that, very brief snapshot of some of the interesting work that we do. I want to obviously all credit to the fantastic team members. We have fantastic undergrads, graduate students, postdocs, technical staff, obviously colleagues and mentors and collaborators. Nothing could happen without the sponsors. We're always looking for more sponsors. And if any of this is interesting or has inspired more questions, certainly feel free to connect with us. I've included my email and the lab web. And also, if you're at MIT, stop by. We're in building 31 and 33. All right, so with that, I will stop sharing and ask Thomas, Professor Helt, to join us as the moderator. And I know Thomas has already been introduced, but I do want to take the opportunity to thank you very much for agreeing to be moderator for this. Greatly appreciate it. As mentioned, Thomas is an alum himself and a professor both in ECS and in IAMS, and in fact, the associate director of IAMS.
So thank you. Thank you, Lonnie. Thank you very much. Glad to be here for this exciting and timely conversation. And before we jump into the discussion, let me make two comments. One, Lonnie, congratulations on the FRAN 2 mission and the hot off the press first in space human X-ray imaging. A fantastic achievement for you, your team, and your collaborators. So number one, congratulations. And the second comment I would like to make, it's really a pleasure to listen to you here and knowing the long and rich history that MIT has had over many decades in not just aeronautics and astronautics, but human space life science. You certainly carry that tradition forward. So thank you very much, from all of us, both active duty and faculty, students, and alumni. So with that, let me get right to the questions. Let me go to the first one. Since the heart does not have to pump as hard in space, will it decrease in size over months?
Yes. So the heart is a muscle, just like all other muscles. When it does not have to fight gravity, and pull the blood up despite of gravity and pump it through the body, the work on the heart is easier. And so it does atrophy, just like all other muscles. I will say, though, so if you look at the wall thickness of the heart, it will atrophy to some extent. The heart itself actually gets a little bit bigger just because the filling of blood is increased. So just like a balloon that's inflated a little bit more. So it does actually look bigger on an X-ray just because of the increased filling, but the muscle itself, if we don't use the countermeasure program, the astronauts work out rigorously 2 hours every single day or 6 days of the week. And one of the reasons they do that is to maintain cardiac function.
Thank you. Maybe staying at the topic of muscle atrophy, we have one of our alumni commenting that in 1968, I was a human guinea pig, in inverted commas, for studies at MIT for isometric exercise in order to potentially maintain muscle mass. What are the current data on maintaining mass?
Yeah, great question. So it's one of the sort of most apparent effects of microgravity or weightlessness is the atrophy of the muscles. The countermeasure program has evolved dramatically over the last year, and it's actually very efficient right now. We have some of the crew come back with actually increased muscle mass, almost certainly maintained, simply because they follow this rigorous exercise program. But I will say for most of the crew, there is a decline in the muscle mass. The best way to prevent it, what the data shows now, is to do exactly what we do here on Earth. A combination of isometric and aerobic and resistance exercise to maintain all the components of the muscle tissue. It's important, obviously, for the muscles, but certainly also for the exercise capacity. As long as you stay in space, you're fine. You don't really need a ton of muscle mass. The issue becomes when the crew returns to Earth. And so you'll see that when the crew comes back, even if they have followed the exercise or the countermeasure program, they need help getting out of the space capsule. They also have orthostatic intolerance, but they also do need to follow a program post-flight to rebuild muscle mass. So it's definitely become more effective, but we can't fully prevent muscle atrophy in space yet.
Mm-hmm. And so there are 3 questions here that relate to radiation exposure in space. So let me bundle these together. So the first question relates to radiation exposure for humans in polar orbit. How much of a concern is this? And even do we know what that radiation exposure, through the polar orbits is?
So short question is not yet. There will definitely be more data coming on that because we now have had the Frame 2 mission. As long as you stay in low Earth orbit, you're still relatively protected, right? So yes, the radiation exposure is elevated in low Earth orbit, but you're still inside a lot of the magnetic protection from Earth. The real sort of question, for the polar orbits, yes, in theory, the radiation is increased when you orbit the polar, just because of the way that the magnetic field dips in there and gives us both fantastic northern lights, but also a change in the way that the protection plays out in low Earth orbit. So yeah, in theory, there'd be elevated background radiation in that orbit. The real sort of challenge will likely be when we move beyond the protective zones and venture to Moon and Mars. And there are many unknowns in that field as of yet.
So we'll get to that part of the question, but there's another question related to this and related to the Fran 2 mission. By how much did the X-ray, the clinical X-ray that you take, actually increase the the radiation exposure?
Yeah, drop in the ocean. Not much at all. It's a very small additional X-ray or radiation exposure, and by comparison, it's negligible.
And what kind of, this is a very knowledgeable alumnus, of course, or alumna, what kind of informed consent discussion did you have with the crew about the experiments? And maybe talk a little bit more broadly about sort of the approval process of even conducting these kinds of experiments in such an environment.
Sure. So actually, a lot of the process is very similar to when we do human trials on Earth. There's a protocol. There's an IRB review process, ethical approval. There's an informed consent session with the subjects. They have to be informed about the risks, the potential benefits, either for themselves or for the general population. And they have to make an informed decision and consent into it. As with all human subjects at all times, regardless of on Earth or off Earth, it's a voluntary. It's based on a voluntary process. So the subjects will volunteer for the trial, and they can always opt out. At any given point, you can always opt out. So actually, it's very similar to the way we do it in the lab. I will say that the process has changed format a little when we're moving from the regular way that we've done it for a long time now through NASA or ESA with a very procedural and very structured format to the way that research is conducted now with the commercial crew. That process actually does look a little different, and the timelines are very condensed compared to what we're used to. So, as a random example, I think I'm okay to disclose that we pitched this trial back less than a year ago. And so the selection, the implementation, the data acquisition, that process, I think usually would have taken a very long time, was done in less than a year through these commercial flights. So it's very efficient.
Okay. And maybe the final question relating to the topic of radiation exposure is, if you go past sort of low Earth orbit and if you go to long duration mission, what are the additional radiation exposure or considerations for return to moon, possible voyage to Mars?
Yeah, so certainly once you leave low Earth orbit, the background radiation changes, the composition of that changes, and the amount of it increases. So there's more of it, and it looks a little bit more, it looks a little different. We can measure it. We've had probes both to Mars and Moon, so we can measure it. So we know kind of what the level is, how that translates into clinical events or actual physiological impact on a human. We have pretty limited knowledge about. So a lot of the knowledge we have comes from very unfortunate events like Hiroshima or nuclear power plant disasters. And that's a different type of radiation. And so we actually don't have a ton of radiation. I will say from the 12 people that have walked on the moon, there was no measurable increase in the long-term. There's a theoretical risk in the cancer risk for long-term. It hasn't seemed to have played out yet. So we can measure the elevated, but how that actually translates into clinical relevance, we actually don't fully know yet. And it may be that it's just fine.
Okay. All right. So let me ask you a couple of questions that came in about intracranial pressure and variations therein. The first one, are cranial pressure changes when we lie down to sleep important to the brain's waste disposal mechanism?
Someone has been reading the literature. Yes.
As we expect.
Yes, certainly. Not my research, not my data at all, but very important data and very impressive data that shows the significance of the diurnal variation of the intracranial health. So we know that when we stand up, pressure drops in the brain. We know that when we lie down, it increases. We also know that the sort of the action of going to sleep in and by itself has an impact on the intracranial physiology and the way that the rate of water production and reabsorption, and so the whole clearing, waste metabolic clearing process of the brain. We know that the brain produces more water when we sleep, and so that has led to this hypothesis or dogma that the brain sort of washed or cleaned as we sleep. The metabolic waste clearance is increased. Now, it's very interesting if you look to fully understand that data. I would argue that space is actually the perfect experimental platform for that, right? Because you have a no gravity environment, no gravitational stress environment. So you have none of the postural interference, so to say. The diurnal rhythm is also completely externally controlled. We have our own clocks, of course, but from the environmental side of things, the crew in low Earth orbit will see 16 sunrises and sunsets per day. And so the diurnal rhythm really is controlled by external factors. And so it gives you like an ideal experimental setup to really understand these. Now, we don't have an MRI scanner in space yet. And it is difficult for us to do very invasive human testing in space. It's difficult for us to manage adverse events in space. So the risk, the appetite for very invasive and risky trials are not so high. I will say though that I am honored to serve as part of a subgroup of NASA called TRISH, and we have today released a solicitation to actually measure the intracranial pressure in space for the first time. So we are definitely taking steps towards understanding this. I'm on the solicitation writing side of the thing, so I won't be doing any of that research myself, obviously, but certainly very exciting times. And again, space and that environment really is a perfect, in that sense, like a perfect tool or scene for us to really understand this basic human physiology. And
if I might just make one plug for our dear colleague Laura Lewis, who is also a faculty in electrical engineering, but also the Institute for Medical Engineering and Science. And she recently joined our faculty here at MIT, and she's particularly interested in the interaction between cerebrospinal fluid dynamics, the electrophysiology of the brain, and she was the first to have people fall asleep in an MRI scanner to see what actually happens with cerebrospinal fluid flow. So if there's an opportunity to bring Laura, into a conversation like this, I think this would be fantastic. But your answer, Lonnie, is a perfect segue to the next question related to cerebrospinal fluid dynamics, and this is whether the ICP increase that has been hypothesized is of clinical significance in space, and if so, should one place implantable hydrocephalus shunts in astronauts going for long duration missions?
So we don't know exactly what happens to intracranial pressure in space. We've not measured it yet. That is to come, so stay tuned. Next year to two, we will have that data. So on prefacing the next, I'm going to say by saying we just don't know yet. But we have measured, as I showed, we have measured intracranial pressure in short-term weightlessness. And based on extrapolation from that data and simulation data here on Earth, it actually does not seem like we get pathological increases in ICP in space. Not the same as when we talk about pathological increases here on Earth, at least, definitely not in that on that scale at all. And that really was part of the foundational data collection or research that led to that hypothesis that it's a low and slow but a persistent overload of the brain that leads to this remodeling and this fluid accumulation inside the brain, rather than a pathological sort of spike in ICP. So based on that, I would venture to actually answer that question and say no. I don't think that, based on what we know right now, I don't think right now is that it would be justified to place a shunt pre-flight.
All right.
But I like the question.
So let me get to a whole host of questions that relate to multi-system countermeasure, and that has to do with artificial intelligence. Artificial gravity, artificial gravity, and then the first question in that vein is: wouldn't long distance, for example, Mars travel, best handle all physiological problems with artificial gravity via spinning wheel designed spaceships like that visualized in 2001: Space Odyssey?
Yes, I would tend to agree. When I teach this in class, I usually say, well, if you love gravity so much, just bring it back or bring it with you. So yeah, I think it actually would. There are also some disadvantages. So how the benefits are they outweighed by the disadvantages? It's maybe an open question. I'm not 100% convinced. We'll know soon or soonish. There are commercial space stations that are planned and will be launched that will actually be able to create artificial gravity in space. This is carried by VAST, is leading that effort currently. In addition to creating artificial gravity in space, they can actually also spin a little bit slower and then create Moon or Mars gravity, which allows us an experimental platform in low Earth orbit in the close to home, where we can simulate or we can actually test and investigate the effect of Moon and Mars G. If you were to spin the whole spaceship, there is some math that has been done on this by people much smarter than myself that showed that it would increase the sticker price, the price tag on missions to a level where it would be difficult for us to actually do them. It would also extend the timeline, push Mars missions out into the future. We also, if you spin the whole spacecraft, great for the humans, but we lose the weightless environment. Maybe we want to utilize that for other testing. I'll mention, though, just really briefly, that what I showed you with lower body negative pressure, it shifts the fluid down, which is good for the brain, we think. But it also moves the whole person into the device, and it actually pushes the device up against the person. And so it does actually create a mechanical load on the body. We've tested this both in parabolic flights and in the lab, and we can reintroduce a whole body weight of mechanical load on the person simply using the negative pressure. So the lower body negative pressure is, in fact, like simulated artificial gravity. So it's a poor man's version of artificial gravity.
I think you partially answered this, but you alluded to it, and this relates to another question about artificial gravity. Do we need 1G to keep people healthy in space, or do we know whether partial gravity would be sufficient to counteract most, if not all, effects that are detrimental?
$1 million question. This is, in fact, the focus of a big part of my lab right now. And we don't know. Like, we know quite a lot about what happens to the human body in 1G. We know quite a lot by now about what happens to the crew in 0G. We know almost nothing about how to connect those dots. So we know, for example, if you look at the changes in the brain, 1G is enough to prevent that. We know that 0G definitely is not enough. Is Moon G enough? We don't know. How about Mars G? So part of the efforts that we're doing, the lower body negative pressure suit, part of the reason that we've translated into a suit is that also to be prepared. In the event that Moon or Mars G is actually not enough, you can use this countermeasure on surface exploration missions to augment, to increase that partial G back up to 1G or wherever you need that threshold to be to keep our crew sort of safe and healthy.
So we're coming up on time, but we have still a lot of questions to go through. So let's go through a few rapid fire questions here. One relates to, I think, the latter part of the work that you're doing. And the question is, controls healthy volunteers differ from hemorrhaging or trauma patients who are in extremis? In the latter case, those patients will have expended essentially all of their physiological reserves, for example, sympathetics. During simulation, there may be sympathetic reserves, for example, epinephrine, norepinephrine. How do you take that into account?
Sure. I mean, we don't have a perfect one experimental setup fixes all. This is why it's a great question. Shows great insight into. That's actually why we're collecting data from patients. We're collecting data from healthy controls. We're doing it in a highly controlled environment where we can dial the individual factors up and down. We're doing it in a very muddy in-flight environment that increases all of it and changes the temperature and the altitude. So I fully agree. None of them are perfect. We're trying to take it into account by looking at all elements and shining a light on this problem from so many angles that eventually we'll hopefully understand enough to be able to increase survival rate.
One question at the present what is the greatest overall risk of human flight to Mars? What is the greatest health risk, do you think? What might be the rate limiting step?
So actually, I think some of it right now is both the nutritional value. We haven't fully bridged that on how do you pack a lunchbox big enough to maintain health for that long. We don't have fully, medical capabilities down to a T. There's also a little bit of a dark horse in the human factors side of things. How much of a mental stress is it to see everything you've known, that little blue dot disappearing on the horizon, which isn't even there either. So I think those are the major unknowns right now. It's nutrition, it's medical capabilities, and then just the wild card of the human factors.
And then the second to last question, what is the most surprising counterintuitive thing you've learned about the human body in space?
Oh, so much. And I think that's really the strength of space research, because we have these predictions and hypotheses, and then we go test it in space, and then it comes back and shows something different. And so it really, that's what the useful thing is, right? We didn't predict. There's so many surprises. The remodeling of the brain was actually a surprise for the community. I went to med school. Nowhere did they tell us that cerebral health, or the health of the brain, probably depends on gravity. It's just not a factor. No one talked about that. And so we only have that information because of the astronauts. And there are actually many, many examples of this. But I think that's really the strength of it. It really is a unique tool to understand our basic human physiology. That's just priceless.
And I'll take the moderator's prerogative here to ask the final question. And if you can just give us just a sort of vignette. We have many alumni, of course. This is the Alumni Association, who are probably very still interested and maybe even nostalgic about the teaching and the classes that they've attended here at MIT. Can you briefly teach us maybe what's on the horizon in teaching space physiology at MIT and maybe across the Boston area ecosystem?
Sure, great question. So these are good times. We were able to double the curriculum in bioastronautics at MIT. We also have some fantastic new opportunities that have risen in collaboration with the Boston ecosystem. And so in collaboration with Mass Gen, MGB, which is called not MGH, but MGB, we host a variety of educational programs. We actually have a space medicine fellowship based off of emergency medicine right now, but we're trying to expand into other specialties. So we're training specializing in space medicine here. We're linking that back into classes that we teach here in the HST program, trying to introduce some of this into the HST for our medical students. And again, bringing the medical students and the engineers into the same classrooms to really teach this. Space physiology and space medicine is nothing but an interdisciplinary. I mean, it's the most interdisciplinary thing. We can't keep our crew alive for more than 10 seconds without engineering. Certainly can't keep them on for a long-term mission without engineering. And so it really is such an interdisciplinary field, and having that tight collaboration in the Boston ecosystem is sort of the perfect platform to build out both these educational programs and just really lead the research in this.
Well, so that is all the time that we have for today. I want to thank Professor Petersen for sharing her exciting research and insights with us today. It's really a fantastic time to be in this area, as spaceflight is shifting really from the sort of state-sponsored agencies to commercial and anything in between. I also want to thank the MIT Alumni Association for organizing this program and bringing us all together around this fascinating and timely conversation. Thank you for having me, and thanks for all of you MIT alumni and friends. And with that, for today, from Cambridge.